for today. I'm very happy to introduce Dr. Shana Gleeson. Dr. Gleeson is an assistant professor of medicine at the Yale School of Medicine in the section of infectious disease. She's one of our go-to folks for helping us out with all sorts of infectious concerns regarding our transplant patients at Yale, and was a colleague of mine in a faculty development program um, where actually this lecture series was born as part of my project in that program. So it's very happy that she is willing to take the time today to talk to us about donor-derived infections and opportunistic infections in regard to the care of our heart transplant patients. So Dr. Gleeson, thank you so much.
Thanks, Michael. Thanks for having me. So I'll just jump right into it. And just mention, I have like no conflicts of interest or anything like that to disclose. I was just, some of you may have heard as you were coming in, I was chatting with Michael. But I want to also, so like, we're just going to touch on a few key points because this is like an extremely broad topic. And we've got a short period of time. So I just had to kind of hit on some key points that related to donor-derived infection and OI, which is opportunistic infection. And we'll see how it goes. I'd be very open to like feedback for future talks of like ways to adjust it or different things to focus on. I know there's kind of a broad range of people who are here who might have different levels of experience with this topic as well. And then, so like kind of mentioned, we're going to sort of just review some of the strategies or ways we try to decrease the risk of donor-derived infection and just hit on some key aspects of it. And then we'll kind of also look at OI and kind of see like a demonstration of how there's overlap between donor-derived and opportunistic infection as well. So most of my clinical work focuses on transplant ID. And so kind of taking a step back and looking at infection after solid organ transplantation, it's a huge topic. It's like what consumes most of my clinical practice or time. And one of the kind of foundational concepts we think about in transplant ID has to do with like timing of infections after transplant. So this, I don't know how familiar you all are with this. I don't know, you call this figure cartoon. This is from one of these kind of like cornerstone articles from Dr. Jay Fishman, who's kind of like one of these giants in the field of transplant ID, but basically kind of looks at the timeline of infection post-transplant. And this is something that, of course, is not like set in stone because patients don't always, like go by the textbook, but is a helpful way to think about infection risk and like when things are going to be happening. And that's like one key point here. If you look at this, we kind of divide things up within the first month after transplant, and then the first year after that, and then greater than 1 year after. And you can see in this very early period, which is on the of that first 4 weeks, that's where donor-derived stuff kind of lands in. And that's usually, so it's usually a very early thing that's going on after the surgery. So that early period, there are some other things that happen. So nosocomial infections are the other big category that happen in that period of time, or complications of surgery. But then it's really like donor-derived infection, which I put in bold because that's what we're talking about today. And it's not super common to see opportunistic infections this early on after induction immunosuppression. So if you are seeing it, that could actually be a clue. Could it be donor-derived opportunistic infection as opposed to just, a randomly happening OI? So I have a case here. This is a real person that if you're from Yale, you may know them. This is a patient I still follow today. So just to kind of like, I guess, get thinking or whatever. So 48-year-old female with a history of breast cancer who developed chemotherapy-induced heart failure, for which she had to undergo a heart transplant. And so she had induction therapy with bezaliximab, and then she was put on maintenance with Tacro, Cellcept, and prednisone after that. And then 2 days after the transplant is when I met her. I got called because the donor tested positive for a few things. So syphilis, hepatitis C, and influenza A. And so I guess the question is sort of like, what should I do? Feel free to like, you don't have to say anything or participate, but feel free to like jump out. Like if you have any thoughts, like what should I do? Should I like panic? Should I give a bunch of antibiotics? Should I report this to like the OPO as like a mistake that happened? Like that this patient, like that this donor like slipped through the cracks, even though they were positive for syphilis?
Sounds like a big conundrum.
Yeah. Yeah. So call your ID consultant, which is what happened in this case, and have them tell you what to do. Yeah. So like the kind of like the larger question, like I kind of like part of what I use this for, and I've used this example for like other audience as well, is like, is it okay to use an organ from someone you know has an infection? Like, is this a big bad thing that like we had this donor that had flu and syphilis, and then the heart was still used for this patient. So this is a concept I use when I talk to different trainees, like in transplant, like we're often like weighing one thing against the other. And sometimes it's different things that we're weighing. But like in like when I think about these sorts of things, I think about like on one side is infection risk of like, we don't want to do harm to our patients by giving them infections, like through a surgery that we're doing for them. But then on the other side of the scale is sort of this risk of death from organ failure. And so if you're if you're too lackadaisical about it, you could transmit infections that could be life-threatening to a patient. We don't want to do that. We don't want to transplant people and then just have them die of infection. That would be very bad. But if you're too stringent about it, then you decrease the organ pool and you increase the risk of death from organ failure before an organ becomes available. So it's kind of finding that balance between those things where we're not too high risk of infection, but we're like trying to mitigate risks so that we can still have like as much of an organ pool as possible to give people the organs that they need. Because I'm sure you're all aware we have continue to have people dying every year on the waiting list. So how can we mitigate the risk of donor-derived infection? There's a few different kind of things to do. So one is kind of risk stratification based on the donor medical and social history. So that'd be like looking at their medical and social history to see if there's anything there, one that could really truly be a contraindication to them being a donor, and we're not going to accept them for procurement. And I guess I should have said this at the top, but I feel like maybe it was self-explanatory because this is a heart transplant and cardiology audience, and like we're just talking about deceased donors. Like some of this stuff is a little different with living donors for like liver and kidneys, but I'm not really going to talk about that today since we're focusing on heart transplant, which is all deceased donors. So getting, donor medical history, social history, is there anything that like definitely means we can't use them as a donor? Or even if there's things that don't exclude them, like does it give us clues of things we should test them for to make sure we're in the clear before we do organ procurement? And then that kind of along with that clinical assessment of the donor, are they having any signs of active infection? And there's actually, assessment of the organs in the OR to see if there's any concerns on the patient's body or in the organs themselves before using them. And then lab screening of the donor as well. So for risk assessment, it involves a thorough review of the medical and social history, and actually can sometimes involve a clinical review of the terminal illness, because sometimes like what's like listed as the cause of death might not be a super informative or helpful thing, but like the actual terminal illness, like looking at that course will give you a lot more information about like what might have been going on or raise any red flags, like about what I can think of this like patient we had a while ago who was having post-transplant fevers where like there was some very generic cause of death listed, but then he actually like went back and looked at the information in UNET. There was a lot more to it. Like they had come in with rash and fever and untold mental status and all this kind of stuff. So kind of reviewing that, reviewing any cultures or their lab results they might have, and then the social history as well. And this is something that's ideally provided by someone who knows the donor well. And even with that, like I think as we all know, like patients may have things in their history or practices or behaviors they're doing that even people close to them are not aware of. And so even like a family member might not know everything about the patient's history or everything that was really going on. And we always have to keep that in mind, but try to get someone who really knows the patient's medical history as well as like behavioral practices and things like that to be able to provide that information. And so there's this interview or like an assessment that's done with donors. This is from the American Association of Tissue Banks, this sort of standardized interview, which I have here is actually a very long, detailed 23-page document that goes through and asks about medical history, but also a lot of aspects of social history, like travel and drug use, sexual history, things like that, to kind of get a sense of what the donor's risk factors or any like things that might confer a certain risk of infection. And one of the things that, not only this, but one of the things that this is getting at is this idea of increased risk of transmission of HIV, Hep B, and Hep C. So these patients are also called PHS, which is Public Health Service Increased Risk Donors. So, and that specifically refers to increased risk of transmitting these three infections, which has become something that has been I think more of an issue in recent years because in part related to the opioid epidemic. And unfortunately, a lot of people who otherwise might be younger or otherwise have been healthy but dying related to opioid overdose. And if they have a history of, injection drug use and things like that, being increased risk of transmitting these viral infections, but also not wanting to um, totally like disregard like or discount using organs from these people for donation. And so this is a table from some guidelines about this. This is kind of busy, but you could look at this. But it's basically just getting at like like some of the risk factors that would put someone in that PHS increased risk category. So some of this has to do with, high risk sexual contacts, including exchanging sex for money or drugs, having sex with someone known to have one of these infections in the preceding year, incarceration. For Hep C, hemodialysis is considered a risk factor. And you can see here these different risk factors that put people in this sort of increased risk category. And so if a donor is considered to be increased risk of transmission of these viruses, you have to inform the recipient prior to transplant, and they need to consent to receiving an increased risk organ as part of the informed consent process. And then the recipient needs to be screened for these infections post-transplant. If they test positive, then you would give them appropriate antiviral therapy. And so it could raise the question of like, can I just test the donor for these infections prior to transplant? Like if I know they're increased risk, can I just screen them for HIV and viral hepatitis? And if it's negative, I don't have to go through all this like consent and constant screening post-op and things like that on the recipient. And the reason you can't do that has to do with this concept of window periods, which we talk about a lot in ID. So when you get exposed to a virus, there's like a sequence of events that happens. You get exposed to it, and then and then eventually you'll become viremic. You'll have viral replication in the blood to a level that it can be picked up on by a nucleic acid test, we call a NAT or like a PCR test. And then after a period of time, your immune system will make antibodies. We call that serologic conversion. And then you have antibody that can be measured in your bloodstream against the virus. So this kind of shows you that here you have exposure, and it's brief, but there is a window period, also called the eclipse period, before you'll be able to detect virus in the blood. And then there's another window period before you'll detect antibody. And this down here just shows you those periods for the different viruses. So it's much shorter for the picking up on a NAT or a PCR test. It's just like a matter of a few days for some of these viruses, as opposed to like weeks or months for the antibodies. But there is this little window period where if someone, particularly say like someone who's got repeated high risk exposures, like injection drug use, needle sharing, and where you could theoretically miss the fact that they have one of these viral infections even on your testing. So the recommendation is that any donor who's considered increased risk gets not just antibody testing, but also PCR testing for all three of these viruses, which definitely decreases the risk. This is a busy table, but the point of this is to show you that this is showing HIV and Hep C if you do the risk of transmission to the recipient with testing. And so the serology, that's antibody alone versus serology plus a NAT or a PCR test. And you can see the percentage like here, risk of infection. The numbers are low all around, but you can see when you add the PCR test, it really drops low, less than 0.1% for most of this. But it's not zero. And so that's why if they're a high-risk donor, we screen them with PCR testing in addition to an antibody, and then we still test the recipient afterward. So what about other infections besides just like HIV, Hep B, Hep C, things that might be associated with, certain types of risk factors? So this interview gets into a lot of other stuff besides just things that are risks for things like HIV and hepatitis C. Like I mentioned, travel history and other things like that. You can even see on the first page of it here, like where were they born? Where was their occupation? It goes through all sorts of different things. And so this is kind of informs lab screening. So all donors will get certain baseline labs, and then their sort of history and their exposures will add different ones. So like, for example, like actually in the US now, all donors are supposed to be screened for Hep C, at least with an antibody test, even if they're like low risk. But then things like CMV, EBV, those kinds of things we think about it. Like, of course, the donor is going to get tested for, they'll get routine things. But then you're going to use the things you glean from sort of this donor risk assessment, this interview, if there are other things that need to be tested for. So like we already talked about like history of IV drug use, you'll look for certain viral infections. They have TB risk factor screening for that. they're from Central or South America. This is not mandated, but this is like advocated by a lot of experts. And I bring it up since this is cardiology group and like it's particularly relevant for heart transplant for Chagas. So a lot of people would say for, especially for heart transplant, but like if the donor is born in Central or South America, to screen for Chagas in the donor prior, because you don't want to transmit that via heart transplant. So then kind of going back to this case, and for his patient's donor was positive for syphilis, hep C, and influenza. Is it okay to use the organ from someone you know has an infection? Like kind of already like was mentioning in a way, yes, because I mentioned about how recipients who come from increased risk donors get screened afterwards. But it's all like with anything when you're talking about this, it's also like it depends. So again, you're weighing that infection risk versus the risk of organ failure. So you have to kind of think about what's like going to happen if you potentially accept from someone with a known infection. So there are some where you just can't, but it kind of depends on what the infection is and what's going on. It's not like a uniform, like you can't use donors who are known to have infections, or you can. So like, and this is not an exhaustive list, but like in the cannot, like some of the highlights from like the cannot donate column, like active TB. So someone who has like active tuberculosis, like you cannot use that donor like for anything. For Chagas, this is specifically for heart transplant. Actually, you can use livers and kidneys, but some people have a history of Chagas, but for hearts, that you're not supposed to use it at all because of the risk of like overwhelming donor-derived infection. And then I put these last two together with an asterisk. So viral infections of the nervous system or encephalitis of unknown cause. So this is one that comes up for us sometimes on donor calls, where like if there's any suspicion or possibility that this person has like a viral encephalitis or like a viral myelitis, so that could be and especially if we don't know for sure, like they have fever, altered mental status, aspects of their case that look like they could be an encephalitis, but we're not 100% sure what the diagnosis is. Like we haven't clearly defined, is it like this could include things like West Nile virus, you know, and these other like insect-borne things like Eastern equine encephalitis, things like that, LCMV, which is a viral infection of the CNS. Like sometimes there's suspicion something like that might be going on, or it seems like they have an encephalitis, but you're not sure exactly what's going on. These are definitely a no-go, because this is, I don't know how many of you like have read the articles or heard the stories about like organ donate or transplants that happen and then a bunch of recipients die of like rabies or like West Nile virus because the original donor had, you know, rabies or West Nile that was not diagnosed until like it happened in a bunch of the recipients. This is why, because like these types of infections can be fatal. There's no specific treatment for them. And so if we are suspicious that something like that is going on, we can't accept someone like that, even if we don't have an exact diagnosis. For on the other hand, like it's okay for certain things. So like most bacterial infections, even bacterial CNS infections, like most, not all, but most cases of bacterial meningitis, you could even use somebody, but it has to be like, quote, under control. So like on appropriate antibiotic therapy for the particular organism, showing some signs of improvement, like for example, fever improving or like white count coming down. And then you're also going to plan to treat the recipient post-op as well to try to prevent them from having a problem with it. Syphilis, like in our case, is not a contraindication. You can certainly use organs from someone with syphilis, and then you just treat the recipient post-op. Hepatitis C, not a contraindication, especially like over the last several years. It's really been shown that this is safe to do because we have such good antiviral therapy now that to cure Hep C, it actually expands the donor pool quite a bit by being able to use Hep C positive organs and then just treat people post-transplant, and the treatment's super effective. They clear the virus and they do fine. So that's something where it's okay as well. And then there's things where we might not even think about it as like, quote, donor-derived infection, but they are, and they're expected, and we don't say it's a contraindication moving forward. And so by that, I mean things like CMV, Epstein-Barr virus, toxoplasma. Hep C kind of falls in this category because a lot of times it's known that the donor is Hep C positive, and then positive donor cultures. Sometimes that's not known till after donation, and then the cultures turn positive like a day or two later, but sometimes it is known pre-op and you just plan for it. And then you're going to just manage these things when they happen. So for things like CMV and toxoplasma, they're not contraindications. You give post-transplant prophylaxis with things like Valcite and Bactrim. If you know that a donor had positive blood cultures for, say, you're going to plan to be giving 1 to 2 weeks of antibiotics to your recipient post-op, or for things like Hep C, you're going to plan to treat the patient. So going back to this case again of this patient that I had, she was tested for flu. She actually tested negative, but we treated her sort of like a post-exposure prophylaxis with Tamiflu. She got treatment for syphilis, and she labs monitored for Hep C. But like as expected, they turned positive, and then she started treatment. She's actually finished that treatment and has cleared her hepatitis C as well, and she's doing really well now, actually. So that is sort of an overview of donor derived, kind of like when we're kind of like screening for it, expecting it, planning for it. Then there's the kind of, what about the unanticipated donor derived infection? Like you're not worried about anything, or you don't have any evidence of an active infection in the donor, but then something happens. So again, going back to this timeline, that usually happens in the first month post-transplant. So you're talking about very early on afterwards is when that's most likely to happen. Fortunately, it's rare, less than 1% of all transplants this happens, but basically it needs to be considered whenever something unusual or atypical is happening, like unexplained fever, sepsis, sort of an atypical infection you wouldn't expect in the early post-op period. You have to start to be suspicious of that. Or when there's a really early post-transplant infection, go back and see, did any cultures turn positive from the donor? What's going on here? And then also consider when multiple recipients from the same donor develop a similar syndrome or illness post-transplant. If you're suspicious of this, you contact the OPO, the organ procurement organization, right away. You don't have like to let them know you're worried about it. You can also get more information from them, like find out if any cultures have turned positive and if any other recipients are also having issues that are unexpected as well. And then coordinate with them about testing any like banked donor tissue as well as your recipient tissue to figure out what's going on and to see if it actually is coming from the donor and if other recipients need to be notified. And then you can treat with whatever, depending on what it is, with appropriate antimicrobials. So that, I don't know that I don't know if I should just end here, Michael, since it's almost 1 o'clock. I had a case to kind of demonstrate about opportunistic infection and donor-derived
No,
infection.
I think you can keep going, Shanna. I think we're
Okay.
good. Yeah.
Okay. So OIs is like a huge topic. You could do like dedicated talks on just each of like different OIs that happen commonly after transplant. So we're gonna just kind of use an example here to kind of like to demonstrate some principles. So the opportunistic infections certainly can happen at various points post-transplant, but highest risk period, going back to this timeline, is in that 1 to 12 month period after transplant. But the clock can kind of be reset, quote unquote, after treatment for rejection because immunosuppression is intensified. Sometimes people will get thymo or other things that are basically like re-inducing them. And so then you can have to kind of think about the infection risk going back up and the clock resetting at that point. And there's a couple different ways that opportunistic infections can happen. It can be reactivation of latent infections like CMV or TB, things like that. And then infection from environmental organisms. So things that normally we are exposed to all the time, but don't make us sick, like molds, nocardia, PJP, but in the setting of immunosuppression can be really problematic. And so I have a case here to kind of demonstrate this. So this is also a patient that some of you may know from our institution, a 32-year-old male with a history of non-ischemic cardiomyopathy who had a heart transplant 16 months ago, so over a year ago. This is his serology here. So he's CMV recipient positive, and then he's toxoplasma D plus R minus. That means donor positive, recipient negative. And he was treated for an episode of acute cellular rejection about 5 months ago. And he's currently on triple immunosuppression with tacro, prednisone, and Cellsapt. And he completed Bactrim prophylaxis about 3 months prior, and he's not on any prophylaxis at this point. And then he comes in with like high fevers, headaches, myalgias, feeling really crummy, kind of non-specific symptoms. His labs, he's got a mild leukopenia, mild thrombocytopenia, and a very mild CMV viremia at 215. Blood and urine cultures are negative. He gets pan scan, doesn't really show much of anything, and he's still having fevers on antibiotics. So kind of question is like, what would you do next? Or are there any particular things that you're worried about in this patient that you want to test him for or treat him for? Any thoughts?
I usually just call Dr. Gleeson.
Yeah. So I'll just point out a couple of things since we're like about his case, and this sort of demonstrates. So I was saying like we'll do a case that kind of shows the overlap between donor-derived infection and opportunistic infection. So he's toxo D plus R minus, so donor positive, recipient negative. So he's in the highest risk category for toxoplasmosis in the setting of solid organ transplant. The reason for this is because so he's got toxo presumably in the donor heart, but he has never had toxoplasma before. So he has no antibody response to it. He has no T cell memory response to toxoplasma for like his own immune system to try to help control toxoplasmosis. And now he's also immunosuppressed from his transplant. And so he really doesn't have much of an immune response to this organism that is now in his body that he acquired through the allograft. So he's in the highest risk category for toxo. Another feature, he was treated for rejection 5 months ago. So even though he's more than a year out, he's more heavily immunosuppressed right now. We've sort of reset the clock, like I was mentioning. And the other kind of key feature is he's off background prophylaxis for a few months. So these are all clues that toxo may be a problem, which is what the problem was here. So his blood PCR was positive for toxoplasma, and that was the cause of his symptoms. So toxoplasma, for the sake of time, I won't get into detail with this because this is sort of ID parasitology, nitty-gritty stuff, but this is to say that cats are the main hosts for toxoplasma, but other animals, if they ingest like dirt, soil, or like things like that that have the parasite in it from like cat feces, they can get it too. So this, the point of this is that humans can get this a few ways. They can get it from say like cleaning litter boxes and then kind of like ingesting in or in these like microscopic oocysts or parasites that can, but it can also be from like contaminated food or water or eating like undercooked meats if you're eating from a meat of an animal that's infected with it. So there's multiple different ways people can get infected with this. This is kind of showing you like how things are different in an immunosuppressed host or like an opportunistic infection. What is different about it? So toxoplasmosis is something that can infect immunocompetent people, but it's usually not a big deal. So an immunocompetent host, it's usually asymptomatic. Like most people get infected with it and don't even realize it and would only find it out if they got, an antibody testing at some point, like pre-screening, like for transplant. Only about 10 to 20% of people will be symptomatic. It's usually like a non-specific mono-like syndrome or flu-like syndrome, and then often has lymphadenopathy associated with it. Very rarely immunocompetent people can have eye infection, that's rare, but usually it's just kind of this non-specific illness and usually doesn't need antimicrobials. Even if you diagnose it, like even if someone presents to the office with this and you figure out that's what it is, it'll usually just go away on its own. You don't have to give them any antibiotics for it. To contrast with immunosuppressed hosts, so opportunistic infection can be things that don't make immunocompetent people sick at all, but can also be things like this that cause like a mild, no big deal illness in an immunocompetent host, but can be life-threatening in the setting of immunosuppression and inability to control the infection. So it can present like this patient a very like non-specific febrile illness, but can also infect the lungs, cause pneumonitis, you can get encephalitis, brain infection, and then all similar to that, but you can get discrete like brain abscesses as well. That's much more common in the setting of HIV infection with low CD4 count than in organ transplant. But it can kind of go either way, like a general encephalitis or abscess. You can have myocarditis, eye infection, chorioretinitis. And so in transplant, it's most common in heart recipients. You can see it with like liver, kidney, like other organs. You can see it in BMT, bone marrow transplant, but it's most common in heart recipients. And they're the kind of the highest risk of the transplant patients of having issues with this. And like I was saying before, the highest risk is D plus R minus, because again, you're getting the infection in the allograft, but you have no prior immune response to help you control it. And I think the reason it might be highest risk in heart is because it tends to have a predilection to go into muscle tissue. And so it's probably in like the myocytes of the heart and like more density than in things like a liver or a kidney. And usually people get into trouble with this if they're not given prophylaxis after transplant or their prophylaxis is stopped. I won't belabor this, but for diagnosis, this is a pearl for all things, not just toxo. Serology, meaning antibody testing, can be less reliable after transplant because people might not be able to generate antibodies in the same way they could pre-transplant, especially if they're pretty close to their induction period. And so we don't rely on antibody testing as much. You want to get PCR of blood or whatever the fluid is, like CSF, and then tissue biopsy is sometimes necessary too. And then treatment, we do induction therapy for at least 6 weeks, which if you look it up, will tell you this regimen that I have these asterisks with, pyrimethamine plus sulfadiazine plus like a leucovorin. And then you go to chronic suppression, which is supposed to be lifelong if you're immunosuppressed and have had toxo with lifelong antibiotic suppression. The reason I put these asterisks here is because we usually use Bactrim instead. We don't actually use this regimen, even though everything you look up will say this is the first line therapy. The reason for that really has nothing to do with medicine. It has to do with money. I won't belabor this for the sake of time, but I don't know how many of you guys know about Pharma Bro, Martin Shkreli, and how he's this like pharmaceutical mogul who increased prices of a lot of meds, and pyrimethamine is one of them. So you can see this was a New York Times article from several years ago. He increased the price to $750 a tablet. So it's basically, these medications are basically not accessible most of the time, and that's why we end up using Bactrim. And then prevention is a key thing, especially in like particular transplant. So all donors and recipients are supposed to be screened for toxo pre-transplant. You check an antibody and IgG, and then D plus R minus, that high risk category, should get prophylaxis, usually with Bactrim. And then for heart, because again, heart is that higher risk category for heart recipients, it should be lifelong prophylaxis for D plus R minus. And then patient counseling is also part of it. So post-transplant, avoiding like raw or undercooked meats, making sure you have good, clean drinking water. If people have pet cats, trying to avoid changing the litter box, or if they have to do it, wear gloves and then wash their hands. And then also because like, the parasite can be in soil and things like that if animals have been around there. So like for gardening or other activities where they're in contact with soil, wear gloves and then wash hands after that too. Okay, so yeah, so just like that's just one example of something where that's an opportunistic infection, can be very severe and life-threatening in an immunocompromised host, presents very differently in an immunocompromised host, but it can be donor-derived. It doesn't have to be. You could get a new infection from exposure to a cat, but in like a case like this where and it can be donor-derived in this patient who was D plus R minus. So there's some overlap there too. So just some takeaway points. I think, keeping in mind a thorough assessment of donors and screening of donors with blood work can help decrease the risk of donor-derived infection and at least help us plan. And that's what I mean by this point, like a thoughtful approach to infections in the donor allows for more safe transplant. So thinking through what are the things that I can't accept this donor for, and if I can accept them but there is infection, like how, like I want to do thorough screening ahead of time so I can be aware of them and be ready and be prepared for like what antibiotics my recipient might need to keep them safe after transplant. Never, this is like a takeaway point, never accept a donor with an encephalitis-like syndrome of unclear etiology. So someone who came in with like fever, altered mental status, could have been a CNS infection, but we didn't have a clear diagnosis of exactly what it was. Could it have been West Nile? Could it have been rabies? Could it have been LCMV? We don't know. So like, we never want to accept. That's like one of the only times we're very hard and firm. Like we don't want to take someone with viral encephalitis or even something that might be that, because that's where you can get really horrible things like a bunch of recipients dying from West Nile virus or rabies or something like that. This is also where screening about the social history comes in. So like, for example, like there was that like write up in the New England Journal of Medicine when there was rabies transmission that way. And then in hindsight, when they talked more to like friends or family of the donor, they had been camping previously and had been bitten by like an animal of some kind beforehand. And so like doing that really thorough screening ahead of time helps mitigate risk as well. And then think about donor-derived infection when patients have an atypical course or an atypical infection. It's in that early post-transplant period. So it's in that first month post-transplant where we worry most about donor-derived infections. And then contact your OPO if you're worried about it, and get the ball rolling on that. And then just, opportunistic infection is a problem post-transplant. There is some overlap, but of course there's also lots of like difference between the two as well. So I'm a little bit over, I'm like 10 minutes over. Okay, and then post-transplant prophylaxis. We did the example of Bactrim with toxo, but we also use things like valganciclovir for CMV. That helps decrease the risk as well for some of these things. So that's all. I'm sorry for going a little bit over. I hope that was helpful. Please let me know if you have questions or comments or
I think it was really fantastic,
yeah.
Shana. That was
Okay.
a great talk. No,
Okay.
it was really good. It was really, 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 made us engaging with the patient cases. learned a lot from it. So, is there anybody out there with any questions for Dr. Gleason before we let her go? I guess just a quickly thing that I was going to ask you, just kind of had, when you started off, with this huge social history that's taken of the
Yeah.
donor. Now, like, because I can imagine a lot of, um, I mean, I imagine the quality of that history really is probably variable depending on the person who's taking it. And my question was like, do these individuals get quite, are they quite highly trained in trying to acquire this information from donor families? And
Yeah, so it's a standardized interview, like that actually has like instructions, like the exact questions asked, and even has like a little note at the bottom that says like interviewers should mix the appropriate pronoun with other terms the historian can relate to, donor's name, nickname, mom, dad, like whatever. And
mm,
so it tells you like exactly what to ask. But the point that you're making also is like this can miss things. So like
yeah,
it depends who the next of kin is, right? Like if like you have a brain dead donor and their brother is like the next of kin who's answering the questions, like will the brother know the sexual history of the patient? You know what I mean? Like will the brother know any kind of like any and all drug use that might have happened, or you know what I mean? Like
right, right,
all that you don't know, right? Like
yeah,
so that's why they say like try to get someone who's really going to know the answer to the questions, but things can be missed. And I think that's why sometimes there's still like a broad, range of lab testing that's done, especially if the answers to those questions aren't totally clear. Uh, yeah,
yeah. It's a really interesting process.
yeah.
Yeah,
And a lot of times
so
that's not happening where we are, right? Because the
uh,
donors are not always coming from within our own institution. So we're relying
uh,
on relevant information being like put into UNET, right? Like about the donor, because we're not the ones actually going and doing that. The organ
right,
coming from
right,
another
right.
state, right? Like so, yeah.
And so that's an OPO thing, and that's not like a UNET thing or UNOS. That's not UNOS directed. It's
I think
something that's
it's I think
OPO
it's user
specific.
structured. This interview comes from the American Association of Tissue Banks, but UNOS, I
Uh,
think, like monitors all that and
I
stuff, and
see.
some of that stuff will get entered into UNET, that you can access. So, for example, the case example I gave of the patient who had like the donor had syphilis and all that,
Uh-huh.
like that information is you can log into UNET if you have access to it, which I did, and like read about the donor. So like I was able
Right.
to read the donor was like what we call like a PHS increased risk. There were a lot of different risk factors there that were like summarized, like
Mm,
um yeah.
mm, all right. All right. Well, thanks again, and thanks everybody for joining, and have a great weekend.
Thanks very much.
Bye bye.